Welcome back to the psychiatry section. I'm Sam Asgharian, and now we're going to move on to the mood disorders. We'll discuss the subtle differences and the timing that's important for the diagnoses, the adverse effects of all of the different pharm treatments and when to use which specific treatment, and the subtle differences between the answer choices that'll help you clue in on the correct answer on test day. We'll start out by discussing major depression and bipolar disorder and discussing the differences between them. Then we'll look at the subtle differences between those disorders and dysthymia and cyclothymia, and we'll end up with a discussion on bereavement and when to treat it and when to just reassure the patient. We'll start out with major depression. It's a mood disorder present with at least a 2-week course of symptoms, and we'll discuss those symptoms coming up. It's got to be a change from the previous level of functioning. And here's a great drawing by the famous artist Vincent van Gogh. And as you know, Van Gogh had a series of issues in his life and ultimately committed suicide from suffering from untreated major depression. Let's look at the symptoms. So the first one obviously is going to be depressed mood. But here's a good word to know, anhedonia. Anhedonia is the absence of pleasure when you would otherwise derive pleasure from that activity. So let's say that in the vignette it tells you that the person loved fishing, but when he comes to your office and complains about feeling depressed, he also tells you that he goes fishing, but he just doesn't like it anymore. And that's not normal. So that's when you want to get clinically involved and see if there are all the other signs of major depression. So you'd be looking for 4 others. So you want to count for major depression. Once you hit 5, you can stop counting. So are they depressed most of the day? Have they had weight and sleep changes? Are there psychomotor disturbances, fatigue, poor concentration, and thoughts of death and worthlessness? They don't have to have all of these. They just have to have 4 of these plus that depressed mood or anhedonia. Let's say you counted the symptoms, you got at least 5, you counted the duration, it was at least 2 weeks or greater. So if you want to diagnose, you first have to rule out medical causes. There are issues that come up that cause people to act depressed. The most common is hypothyroidism. Without the thyroid hormone circulating in the bloodstream, people can fall under those sleep, weight changes, concentration, and fatigue, right? Think about the number of symptoms that they share in common. So you'd obviously want to run a blood test and check for thyroid hormone. You'd also see neurological associations with the severe neurological disorders such as Parkinson's and dementia. They have comorbidities with major depression. Here we go into the first line of treatment, selective serotonin reuptake inhibitors. So that's the fluoxetine, paroxetine, sertraline, citalopram, and escitalopram. Those are your SSRIs. Those are your go-tos for major depression. So when you prescribe an SSRI, you've got to know that it's effective and relatively has mild side effects. They're less toxic in overdose than other antidepressants. Remember, thoughts of worthlessness and suicide are part of the symptomology of major depression. You don't want to give them a treatment that, if in excess, would cause an overdose. That would be a terrible idea. So if there's some improvement but not full response, the question might be, what do you do next? What's your next step in therapy? The first thing is to increase the dose of the SSRI. It takes a while for these to work or kick in, and sometimes you just have to give a little bit more. You might also want to add psychotherapy if it's not helping with just medical therapy. And the goal of that cognitive therapy is to reduce the depression by teaching patients to identify negative thoughts and develop positive ways of thinking, so you can counter it both from a pharmacological standpoint as well as a clinical standpoint. There are a lot of things to take into consideration with the pharmacological therapies in psychiatry. A lot of things that counteract with each other. So SSRIs can't be taken with monoamine oxidase inhibitors, as they will cause a dramatic increase in serotonin. That's the serotonin syndrome that you want to look out for. So the tip here, though, is that on step 2, you won't see 2 SSRIs from which to choose. So if there's one and the patient isn't on an MAOI, choose the SSRI as your treatment modality for major depression. There are times, though, when the selective serotonin reuptake inhibitor might not be the correct answer choice. We'll discuss those exceptions on this slide. What if you have a patient with depression and neuropathic pain? Then you're going to use desvenlafaxine. That's been approved for both the treatment of major depression and neuropathic pain, such as that you'd see from diabetic neuropathy. What if you have a patient who's fearful of weight gain or sexual side effects? Think about that. If a patient is majorly depressed, the last thing you want is for them to gain weight, so now they have a negative body image issue. Or the last thing you need is for them to have performance issues in the bedroom, and their significant other is going to give them a hard time, and that may further exacerbate their depression. Here, you'd use bupropion. Bupropion has fewer sexual side effects and less weight gain than SSRIs. It's also used as an adjunct treatment for SSRI-induced sexual side effects. So if there are performance issues in the bedroom, think bupropion. Let's test out everything that we've learned on a case. We've got a 45-year-old woman seen by her primary care physician due to complaints of depressed mood, lack of pleasure, sleep problems, decreased appetite and weight, decreased energy, and problems with concentration. She states that these symptoms started when she was fired from her job about 4 weeks ago, and that since then she has been unable to function. So what's our ask? What is the most indicated treatment at this time? So hopefully, as I was reading that long list, you counted and you looked at the duration and said, okay, this has to be major depression. We don't have any other information about her medications, so you can assume she's not on any. At that point, then, you want to go straight to the SSRI. Remember, that was the tip. You won't see two of them, and if you don't, go straight to it. So B, paroxetine, is our correct answer choice. You counted those symptoms. She's got enough to say with the duration she has major depression. And if it's affecting her level of functioning, you don't want to just give her psychotherapy. You want to give her a medication to also help treat her depression. Bupropion, venlafaxine, trazodone are not first-line treatments. Alprazolam is a benzodiazepine used for anxiety. And electroconvulsive therapy, it's not going to be used right away. We'll talk about electroconvulsive therapy later on in this lecture, but you would go straight to the SSRI, paroxetine, and answer choice B. So what you just saw in that last case is an example of this. If on the answer choices you see an SSRI and another antidepressant medication or medications, pick the cleanest one in terms of side effects, and that's the selective serotonin reuptake inhibitor. Moving on to bipolar disorder, here you've got a mood disorder where the patient experiences two things: manic symptoms that last at least 1 week, cause significant distress in the level of functioning, in addition to the depression, right? That's the bipolar. It's the comedy and tragedy. They feel really high, and then they feel really low. The symptoms for bipolar are pretty severe. They'll start out with elevated mood and increased self-esteem, a sense of grandiosity. They'll think that they're the next president of the world, or that they're the chosen god of the universe. In addition, there'll be pressured speech. That's another really good one with the distractibility. What you note here is that they speak so rapidly that there's no pause or break in their speech. A decreased need for sleep, as well as an increase in goal-directed activity. So you combine these two, and at 3 or 4 in the morning, they'll go buy a very complex jigsaw puzzle or a model airplane, and they'll put that together in the early morning while everyone else is asleep. Racing thoughts and excessive involvement in pleasurable activities. These are both sexual as well as economical. Whereas before they weren't promiscuous, during these manic symptoms or periods of mania, they'll have hyper promiscuity. They'll be sleeping with multiple partners in a short period of time. Or they'll be going on lavish vacations or purchasing cars or jewelry where that's not normal for them. And look for subtle hints in the vignette, such as when they searched their belongings, they found receipts for expensive purchases, such as a car or jewelry. Note that bipolar disorder typically starts with depression. So they'll come in and they'll say that they have the signs and symptoms of depression, and you'll treat that. And the diagnosis, though, you have to exclude drug use if there's mania present. The reason for that is look at all the symptoms we just discussed for mania. That's very similar to someone who's on cocaine or amphetamine. So how do you note if it's bipolar or if it's just drug abuse? At that point, you just do a urine tox screen. So in the urine, you're looking for cocaine or amphetamine or their byproducts and metabolites. If it's negative, then you can rule in bipolar disorder. One thing that they like to do on the exam is they'll have those 2-part questions. Those are the ones that are in series with each other. So you have to answer the first question before you see the second question. And once you answer the first question, you can't change your answer to that question. So they'll say that the patient comes in and they have all the signs and symptoms and the duration for depression, and they'll say, what is the diagnosis or what's the treatment? And you'll pick depression or SSRI respectively. And then on the follow-up question, once you see it, it'll say something like the patient returns to clinic after X amount of time. And now they have all the signs and symptoms of bipolar. So they'll list them. They say the patient has not slept in 3 days. They've spent a ton of money. Their wife is mad at them because they've slept with multiple partners. So then they'll say, what's the actual diagnosis or what now is the treatment in addition? So you can pick those answer choices. That's another thing they like doing on the exam. The difference between mania and hypomania is the severity of symptoms, the level of functioning. So for mania, the severity is large. You're going to admit these patients. You want to make sure you don't let them leave. They're sleeping with people. They might be at risk for sexually transmitted diseases. They're going to go bankrupt if they keep spending money the way that they do. So the level of functioning is severely affected. The duration, too. So for mania, it's going to be greater than 1 week, and it's going to obviously affect their functioning and warrant hospitalization. For hypomania, it's less than 1 week. It doesn't severely affect their functioning, so you can treat them on an outpatient basis. There's two types of bipolar disorder. Bipolar disorder type 1 includes mania and depression. Bipolar disorder type 2 has hypomania and depression. That's the difference between them. So remember the severity. If there's enough to warrant hospitalization, that's bipolar disorder type 1. If there's not enough to warrant hospitalization, then you can say it's bipolar disorder type 2. Here on this case, we've got a 21-year-old college student taken to the university clinic after she was noted to be acting bizarrely in class. She's talking fast and reported that she has not slept for over 4 days. She appears to be giggling and not paying attention in class. Her roommate reported that she'd been drinking alcohol excessively over the last few days and has had many sexual contacts with unknown men. So what's our ask? What is the most likely diagnosis? So hopefully with all of that, you're wondering, is that affecting her functioning? Does that warrant hospitalization? And hopefully you said it does, and that gives you B, bipolar disorder type 1, as our answer choice. That pressured speech, that lack of sleep for 4 days, that's clinically significant. She's distracted. She's doing pleasurable activities to excess. So that alcohol and sexual promiscuity is going to clue us in on bipolar disorder type 1. Not alcohol-induced mood disorder. There's no history of alcoholism. It's not hypomania. This is severe. And she doesn't have those psychotic symptoms. So it's not going to be anything with psychosis. And we haven't discussed cyclothymia yet, but it's not hypomanic episodes and mild depression. It's definitely mania, and later on this might be precipitated from being treated for depression. But for right now, all you need is the mania. You know it's bipolar disorder type 1. So for bipolar disorder's treatment, you have to distinguish whether there's acute mania going on, or if it's bipolar depression, and you might precipitate the mania if you don't also treat the bipolar. So if it's acute mania, the first line treatment is lithium, valproic acid, and or atypical antipsychotics. You also want to make sure if there's severe symptoms, you use those atypical antipsychotics right away because they have a shorter onset of action. If it's the bipolar depression, you still use lithium, but you also might want to consider adding lamotrigine into your treatment protocol. Important things to note for bipolar disorder are if the kidneys are compromised, you don't use lithium. Lithium is known to be nephrotoxic. So if there's a kidney function example in the vignette and it tells you this is their creatinine or this is their BUN, and if it's elevated, don't prescribe the lithium. And lithium, though, is going to be the correct answer choice to most bipolar questions. So if it's there, what do you want to treat or what do you want to add to the regimen? And lithium is one of the answer choices. Choose lithium. I really like this case. This is a 33-year-old man taken to the emergency room by police after neighbors complained about his behavior. His family informed the doctor that he's been diagnosed with bipolar and was recently started on lithium. While in the emergency room, he became combative and punched a nurse on the mouth. So what's the ask? What is the next step in the management of this patient? Let's take a look at our answer choices. So let's put yourself in the shoes of the deciding physician. He literally just punched a nurse on the mouth. The nurse is standing there. She's just been punched on the mouth. Are you, the attending physician, going to obtain a lithium level? Your nurse has just been punched in the mouth. She'd be pretty upset if you asked then to obtain a lithium level. Now he's combative. Are you going to admit him to the psychiatric unit where he'll probably punch the psych nurses in the mouth? Never a good idea. On step two, it's also never a good idea to refer if you can do something right then and there. Remember, you're a physician. You want you to act like a physician, not someone who just refers left and right. So you're not going to refer to psychiatry because then psychiatry is going to yell at you for giving them a combative patient. Are you going to add valproic acid? That's not a bad idea, but he just punched a nurse on the mouth, and valproic acid isn't going to stem that combative behavior. So you'd see E, the atypical antipsychotic olanzapine. That's where you want to go. You want to sedate this patient. You want to stop him from punching healthcare practitioners on the mouth or wherever he's going to punch them next. And you want to keep him sedated. If restraints were an option, you also want to keep him restrained. And then you can go and obtain your lithium level or admit to psychiatry. But you never want to refer or do things when a patient is combative until you sedate or calm that patient. The symptoms are too acute for these other answer choices, and that gives us answer choice E as the correct answer. We saw cyclothymia as one of our answer choices, so we'll discuss dysthymia and cyclothymia now. You want to count the symptoms again for dysthymia like you do for depression, major depression. Dysthymia is characterized by a depressed mood that lasts most of the day and is present almost continuously. And the duration, remember you count symptoms and duration, the symptoms for dysthymia must be present for greater than 2 years. The treatment is going to be antidepressant meds and psychotherapy. Again, this is kind of like hypomania and mania. It's the severity. So if the number of symptoms and the duration is long, they're just sad, but they're not thoughts of worthlessness and suicide, and it's not affecting their level of functioning as significantly as major depression, then you can rule in dysthymia. So the theme is to count the number of symptoms and note the duration. So for cyclothymia, you're going to see hypomanic episodes and mild depression. So it's a combination of hypomania and dysthymia, right? That's kind of how you can look at it. And again, the symptoms might be present for greater than 2 years. So their highs aren't as high as a manic bipolar person, and their lows aren't as low as someone who has major depression. They're somewhere in between those two areas, and so you can say they have cyclothymia if it's hypomania and mild depression. The treatment is still just going to be lithium, valproic acid, or carbamazepine, and psychotherapy as well. So just note the treatment regimens for cyclothymia and dysthymia aren't that different from major depression and bipolar disorder. So what if you count the number of symptoms, you note the duration, and you're set with major depression, but now you want to look at the types of symptoms and see if they're atypical to rule in atypical depression. These are seen with reverse vegetative changes. Remember the sleep and weight changes that we said are part of major depression? That's normally decreased for major depressions, decreased sleep and weight loss. But for atypical depression, it's increased sleep and increased weight. Increased appetite. They'll say that they're hungry all the time and they're sleepy all the time. So these are the couch potatoes. They'll leave the bed, they'll go to the couch. They'll watch TV, they'll go back to the bed to sleep. They'll go back to the couch, they'll eat something like a whole pizza or a lot of bags of chips, they'll watch more TV, they'll play video games, and they'll go back to the couch. That's atypical depression. The moods tend to be worse in evenings, and they even complain of extremities feeling heavy. They can't move around, doc, that's why I go from the bed to the couch, back to the bed. That's enough to rule in atypical depression. How are you going to treat it? For atypical depression, you still want to go to your selective serotonin reuptake inhibitor. If you don't see an SSRI, then you can feel free to choose the MAOI. The monoamine oxidase inhibitors have been proven to be effective in the treatment of atypical depression. The SSRIs, though, still have that better side effect profile. If you see them in the same answer choice series, choose the SSRIs. And note that basically if you are going to choose MAOIs on step 2, it's going to be for atypical depression. That's when you'll see them. So if you're choosing it and you saw increased sleep and increased weight in the vignette, then you're good to go and it's all right to choose the MAOI. My favorite acronym in all of medicine is the one for seasonal affective disorder. It's sad. For patients who are suffering from seasonal affective disorder, those patients who are sad, you note that these are seasonal changes in mood during the fall and the winter. It's when there's decreased sunlight. It's when the days are shorter, the nights are longer, and the days are shorter, and there's cloudiness and snow and rain. So they'll gain weight, they'll sleep more, they'll be tired more. And you want to treat this actually with phototherapy. You'll actually prescribe that phototherapy, that feeling of warmth and that increase in melatonin in on their skin and in their bloodstream is going to make them feel better. And you can also add bupropion for seasonal affective disorder. A good topic to really have a good grasp on for the exam, something they like to test you on, are the postpartum disorders. So the first one we'll discuss are postpartum blues or baby blues. The onsets are going to be important. So the onset for postpartum blues is immediately after birth up to 2 weeks postpartum. And the symptoms are just going to be that emotional roller coaster. They'll be sad, they'll have mood swings, they'll break down and cry. It's hormonal, it's totally natural. But the feelings toward the baby never change. They love their baby, no negative feelings. And that's an important hint on the vignette. So what are you going to do to treat? It's supportive, reassurance. It's usually self-limited. Once their hormones reset after giving birth, then they usually go back to their normal state of mental well-being. So just note, if you see that female postpartum patient with the emotional roller coaster, breaking down and crying in public, gets really sad, then all of a sudden she gets really energetic, then that is postpartum blues and it doesn't require any treatment. Moving up in terms of severity from postpartum blues, there's postpartum depression. The onset is going to be within 1 to 3 months after birth, so it has a later onset. The symptoms are going to be more severe: depressed mood, weight changes, sleep disturbances, and excessive anxiety. And in the vignette, you want to look at the mother's feelings towards the baby can have negativity. So the mom might say that she has these negative feelings. The difference here between postpartum depression and postpartum psychosis is the mother's fully aware that these negative feelings are incorrect and she feels guilty for having them. So the treatment here, you do want to medicate, you do prescribe antidepressant medications for postpartum depression. And remember, the mom feels these negative feelings towards the baby, but she still loves her child and she is concerned about having those thoughts. So there's good buy-in and they will go on those antidepressants to feel better. The most severe is postpartum psychosis. So the onset is going to be within 2 to 3 weeks after birth, so a shorter onset than postpartum depression. The symptoms are pretty severe. There's depression, delusions, and thoughts of harm to self, to baby, and to others. The mother's feelings towards the baby are severe. There are thoughts of harming the baby. The mom will literally say, I think that my baby is the spawn of Satan, or my child is possessed by the devil. And the mom will believe these thoughts, and she won't feel bad about them per se compared to postpartum depression. For that case, the treatment is antipsychotic medications, lithium, and possibly antidepressants. You want to make sure that mom gets better quickly and that she doesn't harm herself, her family, and her newborn child. So here she actually will say that the child is evil or possessed or the spawn of something terribly evil, and she won't necessarily feel bad about it. That's a severe sign and important enough for you to diagnose postpartum psychosis. Another topic that tends to give students difficulty on the exam is bereavement. And the key here is to note when you treat bereavement and when you don't. And as long as there isn't functional impairment in the person's life, you don't need to treat it. However, it's going to seem extremely close in symptomology to major depression. So let's compare the two. For bereavement, obviously it's going to begin after the death of a loved one. You're going to have feelings of sadness, worrying, irritability, sleep difficulties, poor concentration, and tearfulness. It'll even say on the vignette that the person breaks down into tears in the clinic. Major depression, the reason that you treat it, it's different because ultimately there are thoughts of death, a morbid preoccupation with worthlessness. The person just feels like they're terrible. Whereas for bereavement, they don't feel like they're terrible, they feel like their life is terrible. There's marked psychomotor retardation, there might be psychosis, and that prolonged functional impairment. The durations are going to be a little different. For bereavement, it's going to last less than 6 months, but it can go longer. Whereas major depression, when there's severity great enough to say it's not bereavement, it's major depression, it's greater than 2 months and it's adversely affecting function. So let's take a look at a case. And before we do, let's take a look at the treatment options for bereavement. This is the biggest one. It's reassurance. It's supportive psychotherapy. If it's bereavement and not major depression, you just follow up with them, make sure they're doing okay, and if they need it, you prescribe supportive psychotherapy. You don't medicate. Medical therapy is the wrong answer. So now that you know the diagnosis and treatment, let's take a look at a gentleman suffering from possibly from bereavement or major depression. Here we've got a 65-year-old man brought to the office by his daughter. He has been hopeless and helpless since his wife died 3 months ago. His daughter is worried about his isolated behavior and lack of appetite. He lost over 30 pounds. He doesn't seem interested in getting better and believes he should have died with his wife. So let's take a look at the severity of symptoms, and now what's the ask? What is the most likely diagnosis? So obviously it's bereavement or major depression. We have A or C as our two answer choices. What's the severity? Is this affecting his level of functioning? In 3 months, unintendedly, no one should lose over 30 pounds of weight. That isolated behavior is another issue. It's affecting his level of functioning. He's not going out with friends. He's not spending time with his family. He might be at a suicide risk. So here you would pick C, major depression. That hopeless and helpless feeling, that 30-pound weight loss is really, really significant. That lack of interest and that morbid preoccupation with worthlessness and or death. So you can't say it's bereavement, it's too severe. It's not going to be dysthymia, adjustment disorder, and definitely not bipolar disorder. So you do pick C here, major depression. From the first lecture, I said that a really key point for psychiatry questions are going to be the adverse effects of the medications. So we'll discuss the antidepressants, mood stabilizers, and electroconvulsive therapy a little bit more in detail. So hopefully you have a strong enough understanding to eliminate wrong answer choices and choose the correct ones when you're given the option for treatment plans. For the TCAs, these are the tricyclic antidepressants. That's amitriptyline, nortriptyline, and imipramine. The adverse effects are hypotension, dry mouth, constipation, confusion, arrhythmias, sexual side effects, weight gain, and GI disturbances. And note that these are at a very high toxicity rate risk when they're done in overdose. So this is why SSRIs are so important. If you give someone TCAs and they're depressed, they can actually overdose on their TCAs if they're suicidal. Continuing on, we're going to talk about those monoamine oxidase inhibitors, and it's important to recognize the names because a lot of times you're not told with the answer choice, oh, SSRI, MAOI, or TCA. You have to recognize which drug belongs in which class. So here we're talking about phenelzine, isocarboxazide, and tranylcypromine. So the adverse effects of the MAOIs, remember the biggest thing here is that there's a diet issue. So if you give them an MAOI and they take in foods that are rich in the amino acid tyramine, such as cheeses or red wines, they'll have hypertension and it'll be a significant bump in hypertension. So you tell them, okay, white wine and processed cheese are okay, but red wine, aged cheese, and even chocolate are not okay. So that little smorgasbord that we put together in there again is a painting by Vincent van Gogh, so he pops up often in the psychiatry section. That's a good sign of things to avoid if they're on a monoamine oxidase inhibitor. Another set of drugs that we'll talk about are the selective serotonin reuptake inhibitors. That's fluoxetine, paroxetine, sertraline, citalopram, escitalopram, and fluvoxamine. So the adverse effects, headaches, weight changes, sexual side effects, and GI disturbances. Generally, though, SSRIs are well tolerated. They're not at an overdose risk such as the TCAs, and they do combine with MAOIs, however, to give you serotonin syndrome. That's the other big thing to note for SSRIs. The serotonin norepinephrine reuptake inhibitors, these are the SNRIs, are venlafaxine, duloxetine, and desvenlafaxine. The adverse effects here are hypertension, blurry vision, weight changes, sexual side effects, and GI disturbances. So just note that for SNRIs as well. What about the others? That's bupropion, trazodone, and mirtazapine. Bupropion lowers the threshold for seizures. So if you have someone who's depressed and they have a history of anorexia or bulimia, you want to avoid prescribing bupropion to them because they already have electrolyte abnormalities, and bupropion can exacerbate that issue and send them into seizures. Trazodone has an adverse side effect of priapism. And for that one, look it up on your own. It's a fun side effect and it's easy to remember. So just know that for trazodone. And mirtazapine has weight gain and sedation. So that's the other one to note in the other category. We only have a few more left. So for the mood stabilizers, lithium, remember that nephrotoxicity is really important. So that if they have kidney impairment, you don't want to prescribe them lithium. You also see tremors, weight gain, GI disturbance, leukocytosis, and diabetes insipidus. So if they're constantly saying that they have to get up in the middle of the night to drink water and they're on lithium, you might note that that's its side effect. Unfortunately, too, lithium is teratogenic. So if a woman has bipolar disorder and she becomes pregnant, you actually have to discontinue the lithium and hope that she doesn't have any manic spells during her pregnancy. The severe toxicity for lithium, it's going to be confusion, ataxia, lethargy, and abnormal reflexes. So you really want to get lithium levels and note if they have these symptoms, especially that confusion, that their lithium levels are too high and they're suffering from severe lithium toxicity. Continuing on with the mood stabilizers, we'll discuss valproic acid. Here you see pretty much the same adverse effects: tremors, weight gain, GI disturbances, hepatotoxicity. So nephrotoxicity for lithium, hepatotoxicity for valproic acid. If their hair is falling out, that's probably due to valproic acid. So alopecia is unique to valproic acid. And again, unfortunately, for bipolar female patients who are pregnant, valproic acid too is teratogenic. So you will have to DC lithium and valproic acid. Most obstetricians will actually just monitor female bipolar patients closely during pregnancy because there is no approved medical therapy to stabilize their mood. You do also, with valproic acid, want to monitor levels. The toxicity can cause hyponatremia, so you check their sodium levels. It can lead ultimately to coma and death. So valproic acid is another one that you want to maintain in the therapeutic index. For lamotrigine, the adverse effects are Stevens-Johnson syndrome. So remember, that's a very toxic skin rash where the skin actually starts to slough off. So if they're on lamotrigine, that's what you want to look for. Electroconvulsive therapy leads to headaches, and the biggest one, the reason that we don't do it that often, is that transient memory loss. They'll say that they're very, very forgetful during electroconvulsive therapy. There's a machine that was used when electroconvulsive therapy was extremely popular in the early 20th century. Thankfully, due to medical innovations and pharmacological innovations, we don't have to use that machine as often as we did in the past. We're going to end this lecture with a couple quick questions and notes on psychiatry treatments. What's the single most effective treatment for depression? So you're probably looking, you're saying, well, I see an SSRI right there, so I can pick B, fluoxetine, right? Unfortunately, it's A, electroconvulsive therapy. So remember, the point of the question is what's the single most effective treatment, not what's the single most prescribed or the most popular or the one that you're going to pick on the exam for treatment. You're going to go with the most effective, which is electroconvulsive therapy. The other ones, as you can see now, are equally effective, but the SSRIs are used more frequently due to their side effect profiles. So the one that you want to give the patient, the one that they're going to be most compliant with, is actually B, fluoxetine, whereas the most effective is electroconvulsive therapy, but you're not going to get too many patients to buy into that during the treatment, either at the beginning or throughout the protocol. We discussed earlier what happens if you mix an SSRI with an MAOI. You wind up possibly with serotonin syndrome, and it's potentially life-threatening. If you use these SSRIs, they interact with drugs, they interact in high doses, or with recreational use of drugs such as LSD or the psilocybin in mushrooms that are serotonergic in origin. So remember, an SSRI prevents the reuptake of serotonin from the synaptic cleft back to the presynaptic cell. So you wind up with too much serotonin, so it's constantly interacting with its postsynaptic receptors. What you see symptomology-wise is cognitive effects, agitation, confusion, hallucinations, and hypomania. Those are hallmark signs of serotonin syndrome. Serotonin syndrome can be especially severe. Autonomically, you'd see sweating, hyperthermia, tachycardia, nausea, diarrhea, and shivering. Somatically, you'd see tremors and myoclonus. So what are you going to do to treat? You've got a patient who's hallucinating, who's sweating, whose heart rate is up, they're tremoring. So you'd say, oh, I'd want to treat those symptoms. On the exam, always pick stop the medication, the offending medication, as your first step. You want to DC the SSRI. You might think that's counterintuitive. You want to treat the fever and the diarrhea. That happens second. So treat that fever, the diarrhea, and the hypertension. You can also give them cyproheptadine. That's a serotonin antagonist, and that'll prevent the serotonin from constantly interacting with its receptor, and that'll limit and hopefully discontinue these severe symptoms.